the Medical AI Podcast.
Hello, and welcome to the Medical AI Podcast, a 30-minute thrill ride of big ideas. We are Dr. Felix Beecher and Joe McKeating, and we talk to a range of top guests, from scientists to industry innovators to philosophers. Pat Baird is someone with a true eagle's eye view of the development of medical AI. He is a luminary, a maven, a true wise man. He's somebody who's bringing regulators and developers together and trying to help them to find a way forward. He's the co-chair of the AI Committee for the Association of the Advancement of Medical Instrumentation, and he also co-chairs the AI Committee for the International Medical Device Regulators Forum. Pat, it is an honor to have you on the podcast. Thank you very much for joining.
Why, thank you very much for this opportunity. I really do love being able to take and get the message out and collaborate with people and getting different perspectives.
Great. Well, look, Pat, could you just introduce yourself in general and explain a little bit about your work in medical AI?
Sure. I used to be a software engineer for a medical device company. Had done some human factors work, some systems engineering, risk management, etc. And I got really interested in standards because I was noticing that what the standard said wasn't really reflecting what the reality was out in the field that I was seeing. So now my job is 100% working on standards and just sort of regulatory policy for things. Some of these standards are, just local to my country. Some of them are global. But
And,
I'm
and just to be clear, where your part of the country is the United States, right?
yes, I live about an hour away from Chicago, in the United States.
Okay, great. And I suppose that, do regulators and software developers tend to be very, very different kinds of people, right? So I suppose this is a very, very important gap that you're probably filling. Is that fair to say?
It is, and to me, I like to think of the job as I'm still doing product development. That the product developers themselves need to know, hey, what's the current practice, what's the current expectations when developing something. But the regulators also need to know that too. And I've had several times where regulators come to me saying, hey, we need to work with industry to figure out X a little more. Can you put together a team? So I really love collaborating with these different point of views and coming up with something like a standard, like some training webinar that meets the needs of both of those target populations.
Yeah. And do you want to say something about the organizations for whom you work?
Sure. I work on many different committees and many different organizations. The two things that I think we're going to focus the most on talking about today is um, the one called AMI, Association for the Advancement of Medical Instrumentation. And AMI is a collection in the United States of a bunch of people that are focused on health technology. They're from the hospitals, they're the regulators, they're developers like my coworkers. And what can we do for training? What can we do in developing standards for things? And so and it's referred to as Amy. So sometimes I know when I'm having conversations with people, I'll say Amy, and you think I'm talking about a friend of yours, Amy, and instead I'm actually talking about this association. Uh,
Not Amy Schumer, Amy Winehouse.
yeah, not that.
So, sorry, go
Oh,
on. Go on,
and
Pat.
the other one that I wanted to take and mention, because we got a couple projects there, is International Medical Device Regulators Forum, or IMDRF. And it's basically a bunch of the regulators say, in my country, we're facing this problem. Oh, in my country, we have a similar problem. In my country, we have a similar problem. So it's a place where the different regulators can get together and industry is invited to participate to see, hey, can we align on some things? We're seeing some common problems. Not everything will be 100% exactly the same, across the world, but you know, 80, 90, 95% of stuff is the same. So let's get agreement on some of that. And that could help
Yeah.
drive future policy. So they have a AI subcommittee, and I'm one of the co-chairs for that.
And how would you, if you had to describe in a very short, pithy kind of way, what the state of the medical AI industry and how it relates to regulation is, how would you describe that currently?
So it's interesting because the AI industry, particularly around medical imaging, has been around for 15 years. It's just that the technology has come so far, and we have some technology breakthroughs in the last few years that a lot more different kinds of applications can take and use AI. And so that's it really kind of put the pressure on us. Ooh, we need standards quick. We need regulations quick to know what good
Yeah,
looks like. But the thing is still evolving. So what was good 3 years ago might not be eh, as good as you could do now.
yeah. And I suppose many developers might see regulation as the absolute enemy, because like, if we think about the kind of AI applications that people are getting used to now, like large language models and software for creating music or whatever it might be, the pace of evolution is so incredibly rapid that people must be legitimately thinking, well, what's going on in medical AI? And because medical AI, after all, counts for a lot more than using AI to generate a song, right?
Right. And just lots of different issues to consider, lots of things to learn about machine learning. Particularly in what are some of the different ways that it can fail? What are some of the possibly hidden defects that we have somewhere in our system? How are we going to take and track some of those things down and do root cause analysis if something's going wrong?
So, given this dizzying pace of evolution of AI in general, I mean, do developers in medical AI, in your experience, are they kind of holding their head in their hands and just despairing of the regulatory environment, or are they working with it in a kind of cooperative way? How is the mood?
They are working with it. At least the people that I work with are working with it, and I really like to. I noticed that this group has certain lessons learned, that group has certain lessons learned, and so one of my favorite sayings lately is that for artificial intelligence to work, we need to be better at collective intelligence, sharing lessons learned among us to make things better.
Yeah. Okay, well, look, let's come to the kind of biggest issues that you have to deal with in your work. So, as I said in the introduction, you have an eagle's eye view on the industry in medical AI. Could you just talk a bit about the really key fundamental issues that you are dealing with?
Machine learning is very popular. That's the thing that's surged in the last few years, right before the Gen AI surge. Um, but one of my themes that I sort of picked up just reading different stories of different things failing is I think that we need more than just data. And there's a lot of focus on data, data, data. That's true, but we also need knowledge. We need that context.
Mm.
And I got a story that I always like sharing from a different industry. I was talking to an owner of a McDonald's restaurant, and he was telling me that the corporate McDonald's, where where they buy their fish sandwiches from, where they buy the ingredients that they have for things, monitors your product sales. And it helps you out. If you sell a lot of French fries, then they'll automatically send you more ketchup. So, as the owner of the company, of that particular store, you don't have to worry about, do I have enough inventory? Um, well, this was a owner who was curious about people coming in and asking for a cup of water. Now, they don't charge for a cup of water. He just wanted to know, how many cups of water do we give out to people every month? There's no button for a cup of water on his cash register because they don't charge for it. So he had his staff push the button for fish sandwiches. Now, they don't sell fish sandwiches at this particular location. Uh, and he set the price to zero. But there, he could look up at the end of the month how much fish sandwiches were sold. Well, corporate McDonald's watches the data for him and automatically sends in, the replacement things that he needs. So he started getting all these boxes of tartar sauce because he's selling all of these fish sandwiches. And so I know it's kind of silly and doesn't directly relate to healthcare, but I see the same pattern in some other places of the data not meaning what you think the data means.
Yeah.
And I've also
Uh-huh.
planted that bug in your head, and the next time you go by a McDonald's, you're going to flash back to this story about tartar sauce and fish sandwiches.
Right.
So another example is when I was doing product support. One of the things I would do was take a look at hospitals ordering replacement parts. They could buy replacement parts from me. And oh, if there's a surge in people buying this one particular part, then there must be a problem. Let me go take and investigate it. What I was noticing was a surge in hospitals getting replacement parts in November and December of the year. And I was trying to figure out why. Why? I was like, oh, maybe it's winter coming on. Well, but January and February are much worse than November, December. Why would this be? And so I called around to a couple of my friends that worked in hospitals,
Mm.
and they had the budget that if you don't use all of your budget by the end of the year, management's going to take over that leftover money, and they're going to cut back your budget for next year. So it's in their best interest to spend any leftover money. So they're just stocking up in case there's a
Hmm.
problem in the future. Totally makes sense once you understand that logic, but just looking at the data alone doesn't tell you the story.
We're in a kind of situation where we can build amazing weapons, but don't quite know who to target in a sense.
Interesting metaphor for healthcare.
So, the ultimate lesson here is what, though? Could you crystallize it for us?
There is just such the big focus that you need good quality data, you need lots of data, you need the data from the variety of different sources. And I just keep pushing for yes, that's all true, but you also need to understand what the data actually means.
Yeah. Okay. So that's principle number one. Let's say it's about the meaning of data and the meaning of what systems would do. Could you give us another principle that you work with?
One thing is you need to take and plan for changes coming in the future. You're going to have more data the more your product is used, so you can collect more stuff, more than you had during the product development, and you can take and refine that model and get it out there to your customers. So you have a better model than you did at initial launch because of that extra data. With that, however, you also need to plan for something going bad. Something, there was a problem we got with this one set of data from a hospital that adversely affects what other hospitals are doing. So it's awesome that we can have and move more quickly to update software and give better products to our customers. But we also need to stop and plan ahead of, well, what if one of those things isn't really reflecting reality, such as the November December thing? Um, what do we do to roll back to a previous version? How do we take and control all of that? What do we need to take and communicate to our customers? So plan for revisions and plan for going back on your revisions.
I see. Okay. All right. So they sound like wise words. Okay. So let's move on. Let's unpack this a little bit further. What kind of other principles are most important to you?
To me, we also need to, I'd like to say, improved our collective intelligence. Just there's lots of different ways to fail. As I'm reading these different stories, I'm like, wow, I totally would have made that mistake. A couple of the stories were one was for a breast cancer detection.
Yeah.
It wasn't as effective in African American women because their tissue density was different. Like, wow, as a software developer, I would have thought flesh is flesh and that there is no difference in that. But it was big enough that the cancer looks differently. Um, Another example that I thought was very interesting was, and again, this is sort of one of the drawbacks with the machine learning, is
Yeah.
it looks at the data and finds patterns on its own. It might not be the pattern that you and I see. This was an example of someone trying to write software that takes a look at those little skin tags, little bumps that you have in your skin, and decide
Yeah.
whether they're cancer or not. And what they didn't realize was clinical practice was when you go into the doctor, they think it might be cancer. They put down a little ruler right next to it, so, and then take the image. And that way they could see, oh, it's so many millimeters big now. When the patient comes back later, has it grown or is it just still the same size?
Mm.
Well, because the human was already making that judgment, um, the software came up with the decision that, oh, if there's a ruler in the image, then you have cancer. If there isn't a
Yeah.
ruler in the image, then you don't have cancer. And if someone didn't step back and challenge the software on that, having that extra context and not just having thousands of images. Um,
Yeah.
yeah,
Yeah, no, it's a wonderful example of how machine learning can go wrong. Okay, so look, going back to
yeah.
the breast cancer example and the skin cancer example, are these examples of AI systems which were deployed commercially or just in development or what?
Deployed commercially.
Ah,
Yeah,
okay.
the developers didn't catch it ahead of time.
I guess sometimes. Okay, so some people had a lot of egg on their faces. Then I would imagine. So again, it's a good example of knowing what's going on with your system and what's going on with the data, right?
Exactly, exactly.
Okay, so I think that I mean these are examples of very, very clear ways in which AI systems have gone potentially catastrophically wrong. However, do you also deal with somewhat more philosophical and subjective matters of equity and fairness or anything like that?
So it's obviously a very hot topic lately, and actually, I was working with some folks putting together a little white paper about bias management and overall health equity management, and we're actually in the process of taking and turning that into a standard. I'm going to start nationally just because I can get it done quicker, and then we'll take it internationally. But what I really like about the approach, and this is what I'm trying to do as much as I can for AI, is take the processes and the how we think that we already know that we're already doing for non-AI and see how we can take and apply it for AI. And it might be in an unusual way, but this friend of mine, like I said, when writing the white paper for bias management, he said, "Ooh, let's take an approach like how we do for risk management. Even though some of the stuff might not be directly rated to patient safety, and instead its effectiveness, a lot of designers know what the risk management process is like. Identify sources of problems, evaluate what can go wrong." If something goes wrong, then how bad is it? How much do we really need to take in care? How severe is it? For the things you really care about, put some controls in place. Double check to make sure your controls actually work and aren't, breaking something else. And fundamentally, that's how we do our risk management process. And he's saying, hey, let's
Hmm.
just do the same thing for bias management.
Now, Pat, I know that you've been involved in diabetic retinopathy to some degree. Could you talk about that and how does that how does that illustrate principles in this area?
Sure. And I like to joke that you can't talk about AI in healthcare for more than 20 minutes without someone bringing up IDXDR and diabetic retinopathy. Um, this is one of the more famous examples, obviously, and I think that there's a lot of lessons in here. And this
Hmm.
was actually a physician had invented this, and basically, diabetes apparently can destroy your eyes. And so he invented a product where there's a camera that'll take a picture of your retinas and it will analyze it and see, ooh, do you have this thing that's degrading the retina or not? And instead of just saying yes or no, what it says is, yes, this patient has something that's more than mild. Go see a human expert. Go see the physician that's expert in this, and they make the final judgment. Just in case the software is wrong. Or it says, no, you might have something, but it's mild, and come back in 12 months and get rescreened to see if it's something we need to care about right now. You might have none, or you might have only a little, but that's okay. What I is a great benefit of this is there's not many people out there that are experts in the diabetic retinopathy. And so,
Mhm.
not many people can get screened if we're just based off of human resources. But having this software there to help do that pre screening for the human, I think is great. More people can get inspected, and high risk ones go to the human, low risk ones don't. Even if it doesn't quite catch it, this particular disease happens to move slowly. So waiting a year isn't the worst outcome, as certainly not as compared to some of the other diseases that we're familiar with.
Yeah.
This is
Mhm.
slowly moving. So it's just awesome because more people are getting screened, more people are getting help, and the human experts can concentrate on being human experts.
Now, diabetic retinopathy is an interesting case also because it's, I believe, the first AI system that the FDA ever approved, right? So, which I think was in 2017. So we've had, it's unusual in the sense that we have had quite a few years now of seeing how that kind of system works in clinical practice. So how is that? How have those recent um, 7 years or so gone?
Um, the IDXDR did lay a successful pathway for many other products. I'm not saying that every other product that's out there that claims ML is a variant of this application, but it certainly set the way, and to me certainly um, made the business case for. And I like this term that some of the physicians that I'm talking to, instead of calling it artificial intelligence, they call it assistive intelligence or augmentive intelligence. It's there as a helper. It's not there as a replacement. It's there as a helper. And to me, that's just such an ideal case and a great role model for the other ones to take and follow.
Now, I suppose it. I mean, there may be many situations where humans are, because of limited resources, simply may not be available at all. In those kind of cases, I mean, you can imagine developing countries where they just have very few doctors there per capita. In those kind of cases, these kind of technologies may be exactly a kind of replacing doctors rather than just assisting, right?
Um, it's funny that you say that because I know that in my country we have roughly one physician for every 300 people. I had been doing work with the World Health Organization a few years ago, and I was talking to someone in Africa where his country has one physician for every 13,000 people.
Right.
So any little thing that we can do to make their life easier has a huge impact on their patients.
Yeah. Okay. So Pat, so we've talked about general principles. Could you let's focus a bit more on the problems that have been significant in terms of your experience in regulation of medical AI?
As well as that challenge of having data without having that knowledge, there are some other things that we forget about, and I've been taking a look at other industries just to see what kind of lessons learned from there. And one of the big failure modes that I'm noticing is, as well as having biased data or something corrupt with it, um, is there's also a set of challenges that we forget about because in our experience we deal with it all the time, and we forget to write the software for it. So I remember reading an article one time where people wanted to protest. Their government wanted to put up cameras on every street corner, and they wanted to take in protest, the government being that invasive. And what they did was the protesters put on T-shirts that has someone's face on it, and then they would put paint on their own face. And what happened was then the software, no one bothered telling the software that usually faces are on top of the shoulders. Instead, it just saw them in the middle of the chest and tagged who that person was. There was another one where
I'd like to think, by the way, that there's a significant proportion of our listenership that are practicing anarchists and getting some good tips here.
well, then I have another one for when next time you're driving. Um, Someone had this was self-driving cars, and there was a 35 mile an hour speed limit sign. Someone took black tape and right in the middle of the three, just sort of stuck the tongue out a little longer of the three, and the AI in the car thought that it was 85 and started driving
Right.
that fast. And it worries me because, well, wow, what if they put the black tape vertical instead of in front of the three? Would the software would have thought 135? Um, and so it just, there's things that are so natural to us that we forget about it.
Yeah.
One other, I actually had joined a car standard for a while, not because I'm working on cars, but just to see, what can we leverage from their standards for our medical devices. And I remember reviewing the draft, and it's a section on what does the car do when the stoplight ahead turns yellow. And so I stopped reading the standard, and I wrote down what I think should be, consider how fast is the car going, what's the distance before you brake, either to the intersection or to the car in front of you. Is it icy, or not? I live near Chicago, so of course, we slide around during the winter. So yes, that's what I think the software should do: is speed, distance, and how bad are the road conditions. Fortunately, the people writing the standard remembered one other thing that I totally forgot, which is taking a look in your rearview mirror, because that jerk that's been tailgating you all the time, and just because you can stop in time doesn't mean they can stop in time. And I realized my eyes automatically do that, but it's so automatic, I would have forgotten to write it down. I would have forgotten to tell the AI to check that car behind you.
Now, I suppose when it comes to medical AI, I mean, I can think of an example from my own experience, which is how do you combine scans from different machines? If you're developing an AI system, and I can imagine that even though to a human eye, a scan of an organ might look very, very similar to an AI system, trivial differences might make all the difference, and you might end up with a very biased AI system in ways that you don't really understand or even aware of, right? Is that the kind of thing you're thinking of when it comes to medical AI?
Exactly, yes.
Okay, all right, great. Pat, I wonder, given your wealth of experience in medical AI regulation, if you had a developer coming to you who is brilliant, no doubt, but quite naive as far as regulation goes, and or a CEO of a small company who wanted to kind of be clearer on his strategy for getting products approved, what kind of tips would you give these people in general?
Um, because the technology can be so complicated, and I know that it's difficult, but can you please invest the time in explaining some of these things and being transparent and highlighting the important parts? I know that sometimes we give the regulators thousands of pages of design documentation that,
Yeah.
yes, of course we have a good design. Take a look, and it's half a meter long of your design history file. Um, can you highlight to them what are the important parts that that you did the more than just data, having knowledge, but can you highlight to them and improve what I call the signal to noise ratio in the design files, and show that you cared, show that you did your due diligence, but then show them where you have that, instead of relying on them to take and to follow it. Um, you might have to educate them on that context of use. It's difficult for uh, developers to get out into hospitals nowadays. It's even harder for the regulators to get out there. What I also noticed for a couple things was data scientists. So the people that really know this technology and really know data management, they don't necessarily know the regulations. They don't necessarily know the language. And one in particular, and I want to save people that are listening to this podcast some time. I spent 20 minutes arguing with someone on a conference call, and it turns out that we were using different definitions for the same term. For data scientists, um, bias, is something very specific, and model validation. Validation, podcast listeners know, for our industry is, you know, are you actually meeting the user needs? Not did you just meet all the requirements? Did you meet what the needs
Yeah.
really have for the user? But for AI, machine learning in particular, validation is, oh, is your model valid or is there something broken in it? Is this an appropriate approach? Not, are you actually meeting the user needs? And spent way too much time arguing with team members just to
Yeah.
realize we had different definitions for the same word.
Right. um, that makes a lot of sense, Pat. I kind of rather wonder whether people are at the moment getting large language models to help write their dossiers, and the regulators using large language models to help review their dossiers. And so what you end up with is AI systems reviewing and approving AI systems. That's how the singularity starts, right?
Exactly.
All right. Well, look, you've given a fantastic account, Pat. I wonder. This is the last question. How, as we said, kind of at the beginning, AI systems are developing a dizzying speed at the moment. How could you characterize how things are changing medical AI, and maybe how you see what's the direction of movement in general?
So examples that I'd given about it assisting the caregiver, and can it take care of some of the more routine things. Um, Finding more and more uses, and having it handle some of the, I don't want to say mundane things, but some of
Mm-hmm.
the more straightforward items that don't really need the human judgment in them. um, I also noticed, this is something that I had first heard of several years ago, but I'm starting to see it really surge lately. Is the sort of the Chat GPTs out there. Um, there are certain medical conditions, personal habits that people are embarrassed about. Um, Substance abuse being one of them. And there was a
Mm-hmm.
study that found that people are more willing to open up and be truthful um, to a machine than to a human. They worry about the human making the moral judgment on them of the substance abuse or whatever the problem is, and but the machine doesn't. And so there's certain places where I thought that was interesting, where we might get a someone telling more of the truth to the machine than to the human. Obviously, not everything is like that, but that's a different spot that we're not doing. The other story that I like sharing is, I remember asking a
Mm.
nurse a couple of years ago, um, you know, what's different between now and previously. And she's like, I became a nurse to take care of patients, but I spent all of my time taking care of technology. And so she was, then slapping the side of her monitor, because they spend all their time with the machines and doing the HR stuff
Yeah.
and not actually taking care of patients. And so
Right.
my hope is, can we get AI to do some of the more mundane things and then let the caregiver give care?
Yeah. There is two great examples. I mean, let's think about skin cancer, for example, skin cancer detection. I mean, in general, that is pretty tedious work, right? It may require expertise, but it's not, to imagine trying to sit through 3,000 skin cancer images and classify it'd be pretty mind numbing, right? So what's so interesting about large language models and the emergence of those is that, those are not just doing what we might be tempted to consider mundane tasks. They're involved in tasks that are really quite complicated for
Yes.
humans, right? So, do you think this represents some kind of paradigm shift that we're in the middle of right now?
Um, at, yes, and particularly with just the explosion of the large language models in the last 2 years.
So, Pat, I think you've given a really, really interesting account of quite a few different areas there. So, thank you so much for coming on the podcast. It would be an absolute pleasure to have you back another time.
That would be great.
Excellent. All right. Thanks again, Pat. Take
Thank
care.
you.
Thank you for listening. This has been the Medical AI Podcast. We are Felix Beecher and Joe McKeating. Ping us on LinkedIn if you have any ideas on new guests. See you next time.